So the rationale of the iMODERN study is to compare revascularization strategy for non-culprit lesions in acute STEMI in the acute setting compared to a deferred strategy. So we know from previous studies that patients with acute STEMI, in about half of the patients, have multivessel disease. And from previous studies, we also know that we were not allowed to treat any non-culprit lesions. Now, a few years, the PRAMI study showed the results that if you treat non-culprit lesions, that might improve outcome after all. But that study was compared with doing nothing at all. The hypothesis of the study is that we think that treatment of non-culprit lesions, if they're significant, will abolish all ischemic myocardium and will therefore help infarct healing and improve outcome compared with a deferred strategy. The study design is it's a multinational randomized trial, and we will include 1,140 patients, and the patients will be stratified by acute anterior infarcts. During the primary PCI, which is normal clinical practice, we will ask the patient if they have non-culprit lesions, if they want to join the study, and then they will be randomized to direct IFR measurements, and if it's significantly decreased, they will be revascularized immediately, and that will be compared with the other group, which is a stress testing using CMR scanning. So the rationale to choose IFR in the acute phase is that IFR doesn't use any adenosine to score ischemia in the non-culprit lesions, which is easier to perform in the acute setting. We know that both FFR and IFR are both reliable methods to measure the stenosis grade. For the deferred arm, we chose to do CMR stress testing. So I think that if you treat everything in one session around or during the acute MI, it will be more beneficial and improve outcome compared to if you wait a few weeks. So this study will probably show us that an IFR guided strategy might improve outcome compared to a CMR guided strategy, but we're not sure yet.